Indole 3-carbinol, or I3C, protects against dangerous estrogen metabolites and subsequent prostate cancer. An adequate intake of I3C through vegetables like broccoli, Brussels sprouts and cabbage, or with supplements, might be very helpful for aging men in both keeping undesirable estrogen metabolites like 16-alpha hydroxyesterone in check and decreasing their risk of prostate cancer. Studies have demonstrated the I3C increases the ratio of 2-hydroxyesterone to 16-alpha hydroxyesterone. For men, this can translate to a decrease in prostate cancer risk. In a study that examined the association of prostate cancer risk with estrogen metabolism, the authors said the results of the case study suggest that estrogen metabolic pathway favors 2-hydroxylation over 16-alpha hydroxylation, and this may reduce the risk of clinically evident prostate cancer. Multiple mechanisms by which the I3C can help to prevent oncogenic changes have been shown in preclinical research. A bark extract from the native African cherry tree, Pygium africanicum, has been used in Europe to treat benign prostatic hyperplasia since the 60s, and it's currently the most common therapeutic agent for the condition in France. One theory for the anti-benign prostatic hyperplasia action of the pygium involves the reduced conversion of testosterone to DHT, a potent testosterone metabolite that may exacerbate the benign prostatic hyperplasia via the enzyme 5-alpha reductase. A recent study identified that N-butylbenzene sulfonamide was isolated from P. africanum as a specific androgen receptor antagonist. This inhibits the androgen receptor and the progesterone receptor mediated transactivation, as well as the endogenous PSA expression and the growth of human prostate cancer cells. In Europe, saw palmetto has been used extensively as a drug for reducing the symptoms of benign prostatic hyperplasia. Saw palmetto has multiple mechanisms of action: inhibition of the 5-alpha reductase, inhibition of DHT binding to the androgen receptor, reduction of the inflammatory component of prostate growth by inhibiting the COX-2 and an enzyme called 5-lipooxygenase, by induction of apoptosis and inhibition of prostate cell proliferation. Its clinical benefits related to prostate enlargement include a reduction of nocturnal urinary urgency, a decreased residual urine volume in the bladder, and less discomfort from urination symptoms. Historically, testosterone was believed to promote prostate cancer. This view changed beginning around the year 2000, when evidence accumulated showing testosterone levels were not consistently associated with prostate cancer. Subsequently, the saturation model emerged, and this view suggests that beyond near castration levels, testosterone has little effects on prostate cancer growth. Meta-analyses of randomized control trials revealed either null effects or small protective effects of testosterone therapy on prostate cancer risk. A review of data from 18 prospective studies compared serum concentrations of androgens and estrogens in 3,886 men with prostate cancer to 6,438 healthy controls. The results showed no significant association between the risk of prostate cancer and sex hormone levels. A large cohort study published in 2020 supported the safety of testosterone therapy. Analysis of nearly 70,000 patients with a history of non-metastatic prostate cancer treated with radiation or surgery found that those who subsequently underwent testosterone treatment did not have an increased risk of cancer recurrence or mortality. In more than 500 men diagnosed with prostate cancer who were followed for over a mean of 8.7 years, high androgen levels were associated with a decreased risk of aggressive prostate disease compared with no change in risk of non-aggressive disease. Overall levels of any steroid hormones, except for estradiol, were not correlated with the risk of aggressive prostate cancer. Observational studies and small case series reported testosterone therapy did not increase the risk of the progression in men who'd been treated for low-risk prostate cancer. Larger observational studies of testosterone therapy in men who've been treated for predominantly low-risk prostate cancer did not associate testosterone treatment with poor outcomes. Further studies showed low testosterone levels, in fact, appear to be associated with higher grade prostate cancer. Thus, the totality of the evidence available as of late 2021 does not suggest that high testosterone levels or testosterone therapy increases prostate cancer risk per se. In fact, researchers are actively exploring the risks and the benefits of testosterone replacement therapy among men who've been treated for low-risk prostate cancer. Some men who have symptoms related to low testosterone levels and have been successfully treated for low-risk prostate cancer might be candidates for testosterone therapy. However, consultation with a physician with experience in the area is essential before men in this situation begin testosterone therapy. An increased monitoring of the PSA level might be recommended in this setting. One active area of research focuses on the concept known as bipolar androgen therapy for prostate cancer. This approach entails using intermittent testosterone therapy to cause men's testosterone levels to oscillate between castration levels and high supraphysiological levels as a means of modulating the androgen receptor sensitivity. The aim of this approach is to prevent prostate cancer cells' ability to adapt to very low testosterone conditions. This is an active area of research, and more studies are needed before clear conclusions as to the utility of this approach can be drawn. Despite considerable advances in our understanding of the influence of testosterone on prostate cancer risk and pathophysiology, the use of testosterone therapy in the context of prostate cancer remains very controversial. Data remains sparse in the context of men with low-grade disease who've yet to undergo active treatment for prostate cancer. Therefore, men at a high risk or who have had prostate cancer should not undertake testosterone therapy without first consulting with a qualified healthcare provider who is intimately familiar with the latest literature on the topic. For more information on herbs, supplements, and natural treatment plans, check out my website.